Okay, I think we're ready to get started. Good morning, good afternoon, everyone. Thank you for joining us for today's webinar. Today we're recording, so just want to give you a heads up that we will share the recording afterwards. We're going to collect questions in the Q&A space, and we're going to collect any technical issues in the chat space. And Kristen is going to be our chat manager. So thank you so much for sharing your questions in advance. We will have a Q&A towards the end of our time together today, and we will share those with our speakers. So thank you for putting those in the Q&A in advance. There are captions today, which are found in the transcript space, and I think that's everything for our housekeeping. So thank you again for joining us today, and over to you, Chris.
Great, thank you, Rachel, and thank you, colleagues, for joining us today as part of this discussion of our ongoing series, Crossroads in Global Health. Project Hope recognizes mental health as an essential part of overall health, placing healthcare workers at the heart of our mission. For over 15 years, we've collaborated with local partners to strengthen national health systems and organizations in addressing the mental health and psychosocial needs of vulnerable populations, including families living through war, survivors of abuse, frontline workers, and those who've been forcibly displaced from their homes. The COVID-19 pandemic shone a spotlight on the tremendous burden that healthcare workers face to keep our families and communities safe. In response, Project Hope launched our mental health and resilience training, empowering the health workforce to identify and manage stress and trauma. To date, this program has reached over 100,000 healthcare workers in 41 countries. Excuse me. Through this initiative, we use a training of trainers model to ensure sustainability beyond our intervention, adapting our approaches to meet the diverse needs of healthcare workers across different countries and cultures. Recognizing the systemic and structural factors affecting well-being, we work with health organizations to develop context-specific wellness programs that build resilience among healthcare professionals. These initiatives are not only part and parcel of our emergency responses, but they're also integrated into our broader global health programs, including maternal and child health, HIV and TB, and non-communicable diseases. We emphasize prevention and early intervention, supporting healthy coping mechanisms for youth to protect their emotional well-being and prevent major issues like suicide, violence, and substance abuse. Project Hope is also committed to advocating for sustainable action to improve access to mental health care for vulnerable populations, both domestically and globally. In partnership with the Global Mental Health Alliance, we recently participated in a congressional briefing on mental health and continue to support the MIND Act, U.S. legislation that addresses mental health in foreign assistance. We will continue our efforts to strengthen mental health systems and raise awareness about the importance of mental well-being, to normalize the conversation and break the stigma around mental health for sustainable solutions. And so today we're very excited to be joined by a panel of global experts, including Dr. Mariia Kholostenko, Project Hope's health coordinator in Ukraine, Dr. Paul Bolton from the Bloomberg School of Public Health at Johns Hopkins University, and Dr. Siddharth Shah, CEO of Greenleaf Integrative. And facilitating today's discussion will be the Global Technical Advisor for Mental Health at Project Hope, Pamela Landogno. Pamela, over to you.
Thank you, Chris. Good morning, everyone, and thank you for joining us today for our Crossroads in Global Health series. I'm Pamela Landogno, Mental Health Technical Advisor at Project Hope, and I'm honored to be facilitating our conversation today around mental health of healthcare workers on the front line. So we are thrilled to welcome our speakers today. Dr. Paul Bolton is a senior scientist with more than 25 years experience in global mental health program design, implementation, monitoring, and evaluation. He has led programs and research in every global region, collaborating with international local NGOs and governments. Dr. Bolton was USAID's first mental health coordinator, integrating mental health into other programming. He currently advocates for increase in funding and quality of global mental health programming. Our second guest, Dr. Mariia Kholostenko, is medical coordinator with Project Hope Ukraine. Her work focuses on health equity and healthcare delivery in low resources environments. With experience as a general practitioner in Ukraine, she transitioned to humanitarian work during the war. Mariia has coordinated emergency medical aid in high-pressure areas like Ukraine and Gaza, handling acute crisis and recovery efforts. She is skilled in crisis management, resource planning, and collaborating with local stakeholders to improve well-being of vulnerable communities. And Dr. Siddharth Ashvin Shah, who is a public health scientist and physician specializing in occupational and preventive medicine. He supports programs to become trauma responsive by blending group dynamics, cross-cultural diversity, mind-body science, and prevention. He is the CEO of Greenleaf Integrative, a consulting firm that he founded in 2008 to assist implementers and programs working in high-stakes environments. Dedicated to a holistic and integrative approach to trauma in our sector, he and his team have assisted local and state governments, domestic and international NGOs, and USAID. Thank you all for accepting our invitation today. So before we begin, we would like to mention that today's conversation may be triggering for some of our audience members. So if you or someone you know is in crisis, please reach out to your national mental health helplines. Tomorrow, we celebrate the World Mental Health Day, and in line with WHO and its partners, Project Hope is responding to the call to highlight the critical connection between mental health and work. We recognize the essential role of healthcare workers in saving lives, and we understand that their well-being is vital to ensuring quality patient care. And that is why we are committed to empowering healthcare workers and taking action to protect and promote their mental health of well-being and of the front lines. So today, we aim to engage in a conversation about mental health challenges healthcare workers face and explore what is needed to create better working conditions that supports and promote their mental well-being. As many of us know, working in the health sector can be incredibly stressful. Long hours, work, night shift, weekend work, staff shortage, and exposure to harmful substances. And all this takes a toll on healthcare workers. So these conditions can lead to chronic stress, burnout, anxiety, and depression. In 2022 in the US, nearly half of healthcare workers, that is 46%, reported feeling burnout, and 44% of healthcare workers intended to look for a new job. So the cumulative impact on mental health is profound, affecting not only healthcare workers themselves, but also their ability to care and provide care to patients effectively. So with that said, I would like to open our conversation with a question for you all. Considering these challenges, how do you perceive the current mental health state of frontline healthcare workers? Are there any specific pattern or concern that demand urgent attention? Over to you, Dr. Mariia.
Thank you, Pamela. Good morning, everyone. And when we go back to the question, frontline healthcare workers in Ukraine are facing serious mental health challenges. They're not only dealing with the physical demands of their jobs, but also coping with the high levels of psychological stress. We're often talking about that, but let's try to imagine the stress level that health workers are under. First of all, any medical professionals, even not in conflict zone, is associated with high level of responsibility. Responsibility for human life and health. How heavy this responsibility can be sometimes, especially when it's associated with such things. In a conflict zone, people are under a constant threat of their own lives, permanent fear and unpredictability of tomorrow. But in addition to personal fears, there are difficult moral decisions and their consequences. Deciding which patient should be admitted first, who needs help the most. And afterward, it's natural to wonder if you made the right choice or not. Watching the physical and moral suffering of the people around you does not add resilience and mental stability. Add to this constant overload due to the lack of staff, and what do we get? We will get medical worker not on the verge of psychological trauma and burnout, but already with them. For my personal experience, what the memorable occurred during the difficult week when the one health worker who worked in our MMU program experienced a serious emotional crisis. The team are working in one of the region in Kherson Oblast area under constant shelling and heavy attacks. The team providing medical care in population There is only one medical care providers, this team. And medical worker shared with me his feelings, isolated and depressed because of the tension of the situation. He said he felt inadequate and afraid that he was not doing enough for helping people. I guess this incident highlighted the critical need of mental health support in work environment. Having talked it through, we recommend consulting with our psychologist, and we provide in there also psychologist first aid training session, which include self-help techniques. The change was visible in training itself. The medical worker found the strength to share his experience and feelings. This whole situation reaffirmed my belief that offering mental health resource is not only helpful, but vital. Open discussion about mental health can help create culture of support and resilience.
Thank you so much, Dr. Mariia. Dr. Paul?
Thanks, Pamela and colleagues and Project Hope for inviting us here. I mean, we know workers are under stress. They're feeling burnout, and some of them have frank mental illness like depression, anxiety, and in some cases, trauma and substance abuse. COVID sort of shone a light on this, but it's been a long-standing problem even before the COVID pandemic. Prior to the pandemic, WHO did a survey and found that stress and burnout were problems for health workers around the world, with actually the highest rates being in Africa. The issues, Mariia highlighted some of the issues that we see, with and some of the experience of health workers. One of the things that has come to my attention in the last few years is that as we expand the roles of workers, and then there's a tendency to come in and every time there's a new program or a new type of thing, we add it to the existing workload of workers. So we find that we're expanding their responsibilities without necessarily significantly expanding the time and resources that they have to work on things. So a lot of the challenges that the workers face are actually due to their working environment. And I think that that's something that definitely needs attention. We also don't tend to think about workers as being people. We very often think about them as being program inputs and forget that they have families. And so a lot of the issues that they face in turn affect their families, and then the effects on their families come back and affect them, so that we find that they're in a difficult life situation. So I would echo what Mariia said, which is we need to have more discussion amongst the workers themselves, but we also need access to treatment for mental health disorders because they are actually an at-risk group now. I would class them as being at risk, just as we class other groups as being at risk of mental health issues. The other thing, and it's a particular concern, is that as we open these workers up to start to deal with mental health issues themselves, as we start to provide them with training to deal with mental health, very often we're finding that as the population gets the message that they can start to talk to the workers about mental health, we find that people are often in over their heads. In other words, they receive a basic mental health training, but they get from clients stories and issues that are actually disturbing and they're not equipped to deal with. The longest single meeting I ever had was in Democratic Republic of Congo, where we sat down with local women counselors. And the meeting was supposed to last an hour, but it ended up lasting 5 hours. And I couldn't stop the meeting because it became clear early on that they were venting. They were venting about what they were seeing. They were venting about their inability to deal with issues. They were venting about the fact that they had nowhere to refer people. So we have to be careful about adding mental health to what they do, just as we should be careful about adding any new responsibilities without providing adequate resources. So I'll stop there.
Thank you very much, Dr. Paul. Dr. Siddharth?
I too want to thank Project Hope for bringing us together, especially my two colleagues whose remarks I appreciate very much for just encapsulating the problems that we face. I'm going to focus a flashlight on stress injuries and psychosocial trauma. I aim to equip anyone to better handle trauma rather than the common paths of accepting it or avoiding it. A major reason in the United States that we overlook trauma in healthcare workers is that the preferred term for healthcare professionals not feeling emotionally well is burnout. And there's a consequence to identifying trauma versus burnout because the remedies are not the same. We understand the analogy of needing to determine if a patient's shortness of breath is due to infection, asthma, or constrictive airway disease. Understanding the mechanism of injury allows us to select the best remedies, but this requires we identify the problem accurately. You may ask, why is trauma particularly prevalent within relief work and development work? To that I say, wherever you work, in whatever your context, it is probably not an emotionally easy, well-resourced, secure context. Instead, you are assisting communities damaged by colonialism, racism, tribalism, misogyny, and exploitation. In other words, you work in settings of emotional intensity due to structural violence, which results in an accumulation of historical and collective trauma. Health workers are at minimum exposed to trauma vicariously, and thus are at risk for secondary traumatic stress. And health workers who are from communities impacted by structural violence are likely to carry their own direct and intergenerational trauma. To prevent and mitigate trauma's impacts, I founded Greenleaf in 2008. And in 2008, I was called to Ethiopia by Addis Ababa University when they detected higher and higher levels of trauma within healthcare workers across several disciplines. We trained and supported workers at Blackline Hospital, a level 1 trauma center treating an epidemic of casualties from violence and roadway accidents. And then we shifted to a different profile of healthcare workers at Hamlin Fistula Hospital, a women's healthcare hospital specializing in the many patients who become outcasts and displaced due to obstetric fistula. During my time with these workers in global health, I observed an openness to speak about one's own trauma when the group has first been presented with the neuroanatomy and mechanisms of commonly felt symptoms. The scientific basis of trauma reduced the potential guilt for not being strong enough or having shame for inexplicable symptoms. And I observed that the way an institution takes responsibility matters. That starts with funding the program, including the hospitality of a peaceful lunch and refreshments, and ends with senior leadership participating in potentially the whole program. This further reduced shame, blame, and guilt and created an atmosphere of collaboration and collective responsibility. I want to end on one clarification with a few figures. When we say trauma, the workers who are performing their duties and caring for people are unlikely to be suffering the full-blown psychiatric disorder of post-traumatic stress disorder. The D in that word really makes the difference, a disorder. Those who are functioning fine in their jobs are affected by what we call sub-threshold traumatic stress, below the threshold for diagnosing any disorder, at least a traumatic disorder. Depression and others, of course, require other criteria. As an illustration, in India, 2002, I led a study of secondary traumatic stress of local NGO workers responding to mob and religious violence in the state of Gujarat. There were 72 workers drawn from 4 different organizations. We published in the journal Traumatology that our 17-point scale found that yes, 8% showed probable PTSD. Of course, you can't diagnose with a scale, but 100% endorsed at least some traumatic change due to their work. Also in our study, workers hailing from lower socioeconomic status had higher trauma scores with a p-value of less than 0.001. Subthreshold trauma is again discovered in a recent study of Hruska and others published in the Journal of Psychiatric Research. They studied 832 healthcare workers in early 2021 during the COVID pandemic in the United States. Their results found 47 people consistent with probable PTSD, that's 5.5%, but 471 with subthreshold post-traumatic stress. That's a 10-fold difference at 55%. So I leave us with the likelihood that more than half, maybe all of us in this sector, sustain some stress injury, and trauma may be the mechanism of injury. Thank you.
Thank you so much. Thank you for highlighting this. I think this is really relevant as we're talking about the constant stressors of healthcare workers, how they deal with a lot of responsibility of saving lives that Mariia highlighted, all the responsibilities that they have to deal with, especially, in emergency context, but also the imbalance that we can find between the external demands and their internal and individual resources to deal with their daily life pressures and work-related stressors. So I think this is really, really important. Thank you, Dr. Siddharth, also to raising the importance of acknowledging how trauma is really prevalent among healthcare workers, and how it is important to also identify the difference between stress, burnout, and trauma, also to find the appropriate way to treat and support them. I also highlight how, the access of mental health care and how it is important, of course, to ensure access to them, to these healthcare workers. So we've been discussing about these challenges, and we know that in some contexts, these needs are still overlooked and not addressed properly. So now I would like to invite you to discuss around these initiatives that have demonstrated success in supporting mental health of healthcare workers. Are there any specific actions or programs that you would like to highlight?
Could I start with some? Some various programs have proven effective in supporting the mental health of healthcare workers in Ukraine. One key initiative is training on stress resilience and coping mechanism, which equips workers with practical tools to manage the stress and emotional challenges of their jobs. Psychological first aid training has been also popular, helping staff recognize early signs of mental health issues in themselves and their colleagues. Additionally, advanced training teaches health workers how to provide psychological support to patients, including intervention to prevent and treat the most common illness. It's critical to integrate mental health support into the system than seeing it as an afterthought. During the time of crisis, such ongoing military conflict in Ukraine, it can be difficult to provide high-quality psychological support in certain region. And we understand that psychological sessions require regular and personal engagement. Telemedicine offers a solution by increasing accessibility for it. We, as a humanitarian organization, successfully implemented telepsychological projects in a region like Donetsk and Zaporizhia. Our team of high qualified psychologists, many of whom work remotely, conduct telesessions with medical workers, enabling them to receive effective psychological support. Ensuring client confidently remains a top priority, as these remote psychologists are not part of their on-site team. Unfortunately, often healthcare workers, as ordinary people, live through their personal tragedies, such as the loss of loved ones, forced relocation, and loss of familial lifestyle. At such time, support and professional help is the most important, and many healthcare professionals have benefited from remote psycho sessions to help them get through grief, recover from trauma, and get back to the life.
Thank you so much, Dr. Mariia. Any other comment related to initiatives or programs that you would like to highlight?
Sure, I can add that my team and I always blend practices and team processes to assist the group depending on what they're telling us they're dealing with. Here, I can share 3 group interventions that offer efficacy and diversity in counteracting the impacts of trauma. 1, problem-based learning, which includes role plays, tabletops, simulations based on cognitive behavioral learning. Number 2, mind-body techniques, which include easily learned breathing techniques. And 3, please don't laugh, or actually please do laugh, because yes, I facilitate something called laughter yoga. This is applicable in some settings in which people would say, quote, laughter is dead, or unacceptable in the work setting due to some event. Whether I've done this in Sri Lanka, Ethiopia, or Washington, D.C., I ensure the timing is responsible, the participation is optional, and the framing is scientifically forward. What results is that distressed people report a sense of aliveness and reclaimed joy, a sense of surprise that their well-being could come through instructions of how to laugh, because they've been given permission by an outsider to laugh and be playful. These 3 interventions are delivered in a way to promote social cohesion and provide a stickiness to the learning so that health-promoting behaviors can last beyond the sessions.
Thank you so much. So yes, definitely, Dr. Siddharth, you mentioned a really interesting and important interventions that also put resources in the hands of the healthcare workers and also provide them strategies on how to cope with stressors. And I think that it's really, really relevant. Dr. Paul, do you have maybe any other comment?
I really like those comments. The only things I would add is that I think that part of what we need to do is address the environment that the workers work in, to make sure that they're not overloaded, that they don't have responsibilities beyond their abilities to handle, that they have home time, that they have time off. These are like basic things that are essential to their capacity. The other thing that I've seen, and we have done in some of our programs, is to consider that the health workers and their families are actually part of our priority population. So whatever the program, whoever the program is focused on, that they get priority in terms of access to whatever services we're providing. I think that Project Hope has a good record in this. But one of the things I wonder is whether Project Hope could spread this to governments, to other NGOs. As I mentioned before, not to think about our health workers as just inputs or robots, but to understand their needs and address them as a standard part of programming. Thanks.
Definitely. Thank you for highlighting this. So there is indeed a complex interaction between the external factors, the environment, the organization, and the internal factors. And to me, this underscores the importance of a multifactorial approach to prevent and treat the work-related stress. So it is important to address both the environment, also the personal aspects. So, and that implies ensuring and supporting organizations and developing mechanisms to support the well-being of healthcare workers. So Project Hope has been implementing the mental health and resilience program that Chris mentioned, that also Mariia mentioned, and that now you're mentioning as well. And this program was launched after COVID-19 to respond to the mental health needs of healthcare workers. They were experiencing losses, grief, and constant stressors, and they were living with the constant fear of contagion, of infecting their loved ones. So over the last 4 years, we've been adapting this training to keep on responding to the mental health needs of healthcare workers. Because even if we are not longer in the middle of the pandemic, we are still facing a mental health crisis among healthcare workers. So with our mental health and resilience program, we are making sure to put resources in the hands of healthcare workers. So we empower them by building their capacities to identify the stress response, to develop emotional awareness, and to understand the trauma reactions. And all this is key, as this is the first step to self-care. All starts with being able to identify, how am I feeling? How am I how do I know that I'm feeling stressed? How is my body reacting? And this interaction between mind and body, that it's key in understanding the stress response. And what type of stress I'm experiencing. It is a toxic stress, or it is more like a healthy stress that is pushing me to solve and to face challenges. But all this self-awareness is sometimes impaired by external factors, like the workload, the type of work that healthcare workers are doing, and they are saving lives. So the nature and the personal and professional commitment push them to put others in the first place. So to prioritize others' needs, which is essential when it comes to save others' life. But in the long term, it can be detrimental to their own well-being as they start to overlook their own emotional and physical needs. So in addition to this mental health and resilience program that we have implemented in over 42 countries with more than 100,000 healthcare workers, we are also collaborating with healthcare organizations to identify opportunities to develop wellness programs for their workers. So starting from peer support, as we acknowledge the importance of social connection in the treatment of work-related stress, how important it is, this environment, and the key role that also peers can play in protecting mental health. So even if individuals have an important role in procuring well-being, the organizational awareness is really key. And the recognition of the problem, it's really important and crucial in protecting the employees' well-being. So I think that this is really key. So thank you for highlighting this. So we mentioned the importance of taking into consideration different factors when we are talking about mental health, protecting mental health. And I would like to discuss now about other social determinants, including cultural attitudes and stigma, as this is real important when it comes to talk about mental health. So I would like to hear from you. How do you think a stigma can impact efforts to support the mental health of healthcare workers in your different regions?
I'm happy to start. We know that things vary by culture, how people understand things, how they react to them, what they think is appropriate. But I think one of the things that is more important to focus on is the fact that the commonality across populations, across cultures, is that there's a very negative view of mental health and of people with mental health problems. As you mentioned, I've worked in every global region, and I have many colleagues who've worked in many regions. We don't know of any culture or population where mental health is not extremely stigmatized. And so we need things, we need to have, education of not only the workers, but the populations to try and have a better understanding of what mental health is. And a lot of that education should be focused around really what are a lot of misperceptions about mental health. And one of the big misperceptions about mental health is if you have a mental health problem, you can't do it, you can't do your job, you can't do a job. And so this has been really, it forms part of not just social views, but it also forms part of the laws and part of work structures. So we see in many countries, there are actually laws that prescribe what people with mental health problems can do. Some countries actually prevent them from getting married or having contracts or limiting their employment. Within health structures, there's limitations on whether you can get employed, and if you get employed, whether you can progress. So as well as providing those environmental factors and education and treatments, I think we also need to talk to the organizational structures and the governments about removing punitive laws and punitive procedures and encouraging people and enabling people to get treatment or to get, more general help, and to really basically admit where they're having a problem. So much of health workers' socialization around the world sort of treats health workers as being like supermen and superwomen who can go, do more than other people. And the admission of having a problem is seen as being a weakness. And we need to get beyond that. Thanks.
Thank you so much, Dr. Paul. Any other comments or?
I can just add that not in addition to what I appreciate and what I always use is that ecologic model. And Paul, you've extended it to the economic impacts and the livelihood impacts that would be barriers to dealing with mental health. The only thing I would add when it comes to trauma is that there are biological drivers in addition to negative cultural associations and social stigma. The biological drivers within trauma that are barriers is that people can suffer fight, flight, and freeze reactions, which are physiologically driven reactions. If trauma is brought up in an uncontrolled way, people can have overwhelming palpitations or frozen cognition, sudden flashbacks, or a terrible feeling in their belly. This is because biologically, trauma is a distressing mix of overactive nervous system activity, underactive depressed numbing, and problematic functioning of memory. While it may be impossible to bring the distressing reactions to zero, the skilled facilitator and practitioner will be responsive to the differing manifestations of this fight, flight, or freeze. If we're doing our job well, we're creating an environment of safety, choicefulness, purposeful action, self-efficacy, and social cohesion. Over.
Thank you so much. Dr. Mariia, would you like to add anything or?
Yeah, I would like to say thank you to my colleagues who mentioned all these necessary points, and would like to add only our experience from Ukraine team, that the first challenges we faced here when we developed methods for psychological support for healthcare workers was a strong stigma surrounding mental health, how mentioned Dr. Paul already. In general, but in Ukraine, it's still hesitation to accept that psychological assistance is a basic necessity, and mental health issue remains some kind of taboo. And for example, when our MHPSS team first visited a hospital in Mykolaiv, Ukraine, to offer training on sexual and gender-based violence and psychological first aid training and other intervention, they were met with skepticism. The head doctor confidently stated there were no cases of gender-based violence in the region at all and dismissed the idea that psychological support was needed in general. Overcoming this stigma is the critical steps to cultivate mental resilience and responsibility among healthcare workers. The key role played by state programs and informational campaign. Our team didn't give up and keep talking to challenge wrong beliefs. Over time, the doctors started to understand that just because trauma wasn't visible didn't mean it wasn't there. The promotion of psychological support service through social media and handouts has had a positive impact in Ukrainian society. Nowadays, in a large city, many of health workers understood already the sense and needs of psychological care, but stigma is still strong, especially in tiny villages all over Ukraine.
Definitely. Thank you so much. Yeah, so I agree with you, that there are a lot of negative attitudes and misconceptions around mental health. And this is still, in some contexts, a taboo, where we cannot talk about mental health, that is perceived as something negative. And as Dr. Paul mentioned it, that people believe that if you have any emotional or mental health problem, you are not able to do your job. It's seen as a weakness, especially, in the context of healthcare workers, but they are providing care, and sometimes they are not perceived as they do not perceive themselves as someone that can receive care. And I think that it's important to address this stigma and all these misconceptions. It starts with education about mental health literacy, talking about mental health normalizing the conversation, creating spaces to discuss about all these important things. And of course, as a result of creating, as Dr. Siddharth mentioned, safe environments where people can openly talk about these topics. Work environments where mental health is recognized and acknowledged as a priority and something that needs to be addressed. So definitely, I believe that this is really important. And what stigma do around mental health is that it's impairing people's capacity from seeking help. So the more we talk about mental health, the more likely it is for people to look and seek for emotional and psychological support when needed. So thank you so much for highlighting this. So as we reach the end of our session, I would like to invite you to call to action. So if you could share one urgent message with the global health community regarding mental health support for the workforce, for the health workforce, what would it be?
I could start with that. You know that I'm speaking to you because I'm dedicated to conserving the talents and well-being of the people who serve in this sector. Sadly, this problem only gets worse if we tolerate the distress and hope it goes away in time. So my call to action is that we take responsibility in a shared manner to better handle trauma. Individuals have ways to play their part, teams have a role, and organizations have a duty to act and to self-examine. Two ways that we've seen at USAID with this change of attitude towards the mental health of their own staff and teams and their local partners is that senior leaders, if they have been in counseling or psychotherapy, which is only one of the many ways to manage a mental health problem, but an evidence-based way, they would share with their teams that is what's helped them stay focused and stay in the work rather than being a detriment. Secondly, the organizations have a duty to look at their policy structure where there may be unintended ways in which people will not, that stigma is maintained. One key example being maintaining one's security clearance if that's relevant to a job. There's a policy structure which oftentimes implies that having any mental health services means that you will be looked at with greater detail and that your records will be pulled. USAID started to message with our suggestions that actually seeking treatment is a way to maintain your security clearance, because it is those people who want the distress to go away automatically without treatment. Those people then start leaking behaviors unconsciously or unintentionally. And those are the very things that are problematic to maintain a security clearance because they can be dangerous to self or others. So without targeted attention, trauma worsens and metastasizes. Each of you can help socialize that well-being is not a luxury, but an occupational duty. Over.
Thank you so much. Councilor Paul?
Great comments. I think the message should be that for health workers, this is a stressful job, and that therefore maintaining mental health should be just a standard operating procedure. It shouldn't be something that people have to seek out or ask for. In the light of all the stigma that there is out there, it's just less likely that people will do that. I mean, all of us, we have our primary devotion is to our families. So, and we have to make a living. If you think that, coming forward with a mental health problem is going to affect your ability to support your family, there is no way you are going to do that. So we need to change that attitude, but we just need to make this kind of support standard, that everyone gets some basic level of support in terms of environmental changes, in terms of knowledge and basic skills, and that in that education is the promotion, as Siddharth said, about seeking help as being a good thing. Because you have a choice, right? About 10% of our populations and more for health workers are going to develop a mental health problem. what's better for the organization, that they get treated and they function better, or that it stays hidden and they function at a lower level. We have to realize that, we're not going to suddenly have no workers with mental health problems simply because we forbid it. I'll stop there.
Thank you so much.
And as for me, if I could convey one urgent message to global health community, it will be the following, so short. Prioritize the mental health of our healthcare workers as the most important, non-negotiable aspect of healthcare delivery. The well-being of health workers is directly linked to the quality of care they provide. By investing in mental health support, we not only protect our workforce, but also improve the overall effectiveness and sustainability of our healthcare system in general. Recognizing this connection and taking action to create supportive environment for those who dedicate their lives to caring for others is essential. That's it.
It is. Thank you very much. And I would like to thank you for your time, for sharing your thoughts, and for being with us today and illustrating all these challenges and the things that we can do to face it and to address it. So now I would like to turn to our audience and open the floor for some questions that you may have. So please send us your questions in the Q&A chat box. Chris?
Thank you, Pamela. Thank you, colleagues. There's so much to unpack here and so many questions that I have, but I realize we've just got a short period of time, so I'll try to keep it tight. Firstly, a huge thanks to Dr. Siddharth for the importance of distinguishing between burnout and trauma, and very importantly, identifying the distinction of disorder within the PTSD element. Certainly in emergency response, we hear way too much about traumatized populations. It's in the media, it's everywhere, it becomes part of our normal lingo, and it's very suggestive that everybody needs some kind of clinical intervention, when of course, many studies have shown that populations that have experienced trauma, 90+% of them will completely heal through the establishment of safety, security, access to basic care, and reestablishing community support networks. And the focus should be on those elements there, and then for the smaller subset that do develop disorders through that's where we want a more involved in clinical intervention. But your concept of subthreshold post-traumatic stress is very new to me, and I don't know that we have time to unpack that today, but it's definitely something I'd love to put a pin in. And I really appreciated the comments around the health worker and the concept that we think of them as superheroes, and they're not. They are heroes by all means, but they're not superhuman. And the stressors that they're under, not just in the care that they have to provide, the empathy that they need to have, but in these contexts, they are very much part of the affected populations. As we speak today, our teams in North Carolina are seeing frontline healthcare workers that are 10 days on, working all out and completely running physically and emotionally on fumes and are just exhausted. The teams Mariia runs in Ukraine, they're going to the populations that are most affected, and these are on the front lines. These are in the most dangerous parts of the country. And in COVID, we saw health workers sleeping in their cars because they were afraid to bring home a very scary and unknown disease to their families. The populations that we see, they're very much affected by the same issues and events that are affecting the broader population, and they're not immune to it at all. So I really appreciate the attention to that. If I could pose one question, I think I would direct it to Dr. Bolton and Mariia. You talked about the stigmatization of mental health, how we overcome that. Ukraine had a very centralized approach, kind of a classic approach to treating mental health, where they have large mental health institutions separate from the communities, moved away, and everyone was pushed there. It was a horrible model for treating it, and it was certainly a model that helped promote the stigmatization of it. And we've known and we've learned that a more community-based approach is going to be more effective. It's going to reach more people, it's going to have variated levels of care, and it's going to help reduce the stigma. Are we seeing any of that? We know that there's been a big investment in mental health and at least at a high level within the Ministry of Health in Ukraine, a recognition of a need to transition out of this kind of historic Soviet model. Are we seeing any progress there, whether on the ground where you're working, Mariia, or with the work that you've done, Dr. Bolton, with policy?
Could I start to answer? Thank you, Chris, for your question. Yes, you mentioned the key role in this efforts is played by state program and informational campaign at reducing stigma and combating the sense of shame associated with seeking psychological care. Yes, the key role played by the governmental program, and already in Ukraine we saw that a lot of medical workers who work in big, large cities understand the necessity of psychological support. They ask us about providing some session and trainings which can improve their knowledges and skills. They already know how to provide basic psychological care support. But the stigma is still strong in teeny village. When you go to some teeny villages in Kherson region, even if it's Odessa region and Mykolaiv, you will faced with stigma, skepticism, and not understanding that psychological support is needed. And this is a field for working. It's field for work for us and for governmental program as well.
I don't have much to add. I have worked in Ukraine since about 2015, before the war, where we did programming there. And as Mariia said, we just found, the whole issue of mental health to be a problem. It was institutionalized in the sense that if you presented with a mental health problem to a psychiatrist, then you were put in the hospital. That was where the initial management took place. So suddenly you're a hospitalized mental health patient. And there were even laws prescribing in the future what kind of work you would be allowed to do, what positions you would hold. So people would not want to do that. I think that Mariia would know better than me lately. I think there's been progress in trying to roll back and support people. But of course, with the war going on, that hasn't been, a focus. But I think that there's an appreciation of the need to change. One of the things that we try to do in addressing stigma is how we frame management and treatment of it. When we talk about counseling programs like cognitive behavioral therapy, interpersonal psychotherapy, the other therapies that have been shown to be as effective or more effective than medication, we try to frame this not so much as filling in a disorder or weakness, but it's actually more like going to the gymnasium in many ways, in the sense that it makes you stronger. Like when you go to a gym, you have a trainer and the trainer looks at you and prescribes a set of exercises and then monitors how you do. General counseling and talking therapies are actually the same. And the idea is that you build a stronger mind, you build a more resilient mind, you have skills and talents that other people don't have that can keep you healthy in the future, and trying to frame it as a strength building activity rather than, you're weak. And I find that that's been helpful. The other thing is to try to not lump all mental illness together as if, someone who has depression is crazy in whatever colloquial sense people mean that to be, but it's actually trying to link it more to, our normal experiences. Yes, we all get depressed at times, but some people get more depressed. Some people need more help than others, just like with every other aspect of our lives. Every challenge we face, some people need more help, some people need less. You might not have developed depression now, but that doesn't mean you won't develop issues or later. It doesn't mean that you're mentally stronger. It just means that in that case, you were fortunate not to develop a problem. That's it.
Thank you all. This has been an incredibly informative and candid conversation. We have some wonderful questions in the chat. Unfortunately, with time, I think we might only have time for one of them. Something of interest is that we often talk about minimum initial service packages in development setting, and can we think about 3 packages of essential mental health services for healthcare workers, sort of from the preventative level, basic, and then emergency care and assessment at each of those levels? Over.
Well, for a start, I'd rather not think in terms of minimal packages. I find that distressing because when you implement a minimal package, you've basically ticked the mental health box, right? We're done here. Let's move on to other stuff. What I found with funding mental health programming is that when we do minimal packages, we send a message to the funder that that's all that's needed for mental health. And so the next time around, that's the only resources they provide. That's all they expect to see. So there's this cycle of inadequate or minimal programming. I think we have to more say, look, these are the things we need. This is what a good mental health program looks like, and this is what it requires. In terms of your question about can we identify different packages, there are plenty out there. The problem is they don't get funded and they don't get adequately resourced and implemented. Mariia, Siddharth, do you have anything to add?
I'm glad I didn't open my mouth because the way you responded is exactly the style of championing this cause that I would want. So I'm glad I didn't go right into talking about packages of some sort. I would say in addition to the kind of nuts and bolts of packages, Mariia, you mentioned psychological first aid, strong evidence base, needs to be culturally adapted, which you would do locally anyways. I would add that the institutions need, again, that examination of their policies and processes that might be unintentionally maintaining the problem. So it's not, the responsibility is not only on people taking trainings and doing something extra, but it is a collaborative, collective responsibility, and ideally full of efficiencies. And one of the efficiencies being that if you're learning about, for example, trauma, depression, substance abuse for one's own well-being, it's very likely applicable to the populations you're working with. There's an efficiency there's a holism to this so that people are actually learning other job skills in addition to the job skill of maintaining one's well-being and maintaining and supporting your colleagues. Over.
I totally agree with my colleague. Can I add something that when we're talking about this minimum package, yes, we could think in two ways. First of all, it can be minimum packages for all countries as well and also situation. If we will compare one country with healthcare workers in general conditions and country in crisis, the first difference will be the lack of staff. The lack of staff of psychiatrists or psychologists in Ukraine, we face with it. And our minimum of packages is to teach and try to create skills and knowledges for our doctors and nurses in the basic level that they could providing the basic psychological support. Hope this lack will be covered more and more, how it happening now, but this minimize knowledges and skills, it's a basic, it's for me.
Well, thank you so much. Thank you for your insights and this really interesting conversation, and thank you to our audience for the questions. So now I'll pass it over to Chris for some closing remarks.
Yeah, thank you, colleagues. We're a bit over time, so I will keep this very brief. Firstly, a huge thank you to our doctors on the call, Mariia, Paul, Siddharth, Pamela. Thank you so much for the fantastic facilitation. A lot to take away from this. For me, The concept of the health worker as an at-risk population is huge and incredibly significant, and one that I am going to keep with me and to use. And we also talk a lot about the importance collectively of advocacy around this issue. And as Dr. Siddharth mentioned multiple times, the evidence base is critical to that. Anybody that we're advocating to, any policymakers, they always want to know, what is the evidence base behind it? How can we show that these interventions make a difference in people's lives and are pushing this issue in the right direction? So colleagues, thank you so much for your time. We look forward to seeing you next time at our next discussion in Crossroads in Global Health. Thank you.